Recolcolia is you see the white color through the eye exam, and it's usually prompt out the differential diagnosis of the retinoblastoma, and this is the secondary malignant tumor of the osteosarcoma. All right. Okay, that's hematology oncology. Move on with the question. All right, a neonate have aniridia of the right eye on the physical exam. The child born spontaneous vaginal delivery with uncomplicated full-term pregnancy. The rest of the exam is normal. So basically, just keyword is aniridia. Which of the following is the most appropriate next step before the infant is released from the hospital? So you find one thing abnormal, and you'll have to look for the association. What should be the answer? Help me out, answer it. A, abdominal ultrasound. B, echocardiogram. C, neurological consultation. D, rapid plasma reagents or RPR test, and IV antibiotic as the last answer. So your answer should be, what is it? Someone make the sign. I don't know. I don't have X as the option. All right. Oh, I think he probably make A. I'm sorry, I misunderstood as X. So it's A, the abdominal ultrasound. So you have to know the associations. Aniridia is the conditions that the persons have absence of the iris. So compare between this one is normal iris and the one without iris. So it can be inherited as autosomal dominant, and 1/3 of them has the association with Wilms tumor. That's the reason why we have to do abdominal ultrasound in the kids with this condition. So in practice in America, if you find some abnormal finding in newborn, you have to look for the other one. Like if you find like the ear tag or sinus of the ear, you have to look for that the abdomen. They may have the association of the renal abnormality. So you have to look for the clue. One clue bring you to the other, and you cannot miss that one, because if the child turn out to have Wilms tumor and they've been recognized that the child have aniridia at birth, you're gonna get sued if you practice in US. So you cannot miss minor thing. All right. Okay, next questions. At 8 hours after birth, an infant have excessive salivations. A lot of saliva come out. Exam reveal imperforate anus and small fistula to the vagina, and small soft endothelium was inserted, and then took the X-ray. The film showed the tube coil back into the upper chest and normal gas pattern in the GI tract. No apparent abnormality of the radius or vertebral body. Which of the following is the most appropriate next step in management? So another association, right? You find that scenario suggests, what is this scenario that they give you? What is the diagnosis from this scenario? Esophageal atresia and T fistula, right? At least because normal bowel gas pattern in the lower GI tract. So there's some air get in despite the esophageal atresia. So the association of this question should be what you're looking for, vectoral association. All right, but despite you know that, you have to get the risk that, oh, okay, something has been done, so what else you should looking for? So what's the answer? A, right. You have to look for the heart disease and also renal ultrasound. That's the answer, and vectoral, you have to remember. Another application of knowledge in the recall question, I think. All right, next. Neonates have abnormal shape of the face with small jaw. Several hours after birth, the infant develop convulsion, tetany, and the chemistry show as follow: sodium normal, K4, chloride 100, bicarb 24, MAC 2, calcium 5, glucose 100. What is abnormal in the list of the tests? Calcium, hypocalcemia, right? Okay, the child disorder is associated with hypoplasia or aplasia of which of the following organ? D. Someone answer D. All right, you follow her? All right. So definitely it's not as that hypoplasia of thymus is not associated with the calcium, but you have to know the conditions that the child have discharge or that 22q11 deletions that compose of that characteristic facial abnormality as they described, and the child may have that underdevelopment of thymus and hypoparathyroid gland that's cause low calcium and cause seizure. All right, that's all the sample of genetic and dysmorphic syndrome. Okay, we move on to the other part of questions. A mother bringing a 6-year-old daughter for evaluations. She has never been able to toilet train. The child said that she perceived the sensation of having to void and empty her bladder normally at normal interval, but is nevertheless with urine all the time. The other word is leakage. Which of the following is the most likely diagnosis in this chart? So she felt it, she can go to the bathroom, she can void, but there are also some leakage. What is the condition? Quiet. It's not a good sign. You hungry already? Is that the sign of hypoglycemia? Huh? Don't faint out. Get some candy. All right, I give you the answer. Well, the answer is A. All right. The reasons that one ureter connect to the bladder normally, that's make her feel that she have the sensation that she need to void. It can fill the bladder. But however, the other one is get lower, and that's cause the leakage. That's constant leakage. So the treatment is the implantation of this ureter to be normal position. So it's the classic scenario. If you get used to this kind of question, next time you get it right immediately. Just solve once and then answer it. All right. Okay, but these conditions, despite it occur in boy, the boy will not have the symptoms because of that urinary tract of boy and girl is different. The boy is longer, so they don't have the leakage much as girl. All right. Next, 7-year-old boy, history of UTI. Repeatedly, treat with empirical use of antibiotic. The parents are not satisfied with the care of the child is receiving and took him for urologist evaluations by VCUG, the voiding cysto ureterogram, show the patients have vesical ureteral reflux. VUR, we get used to all the abbreviations, without urethral or upper tract dilatations, or just only grade 1 of the reflux. Which of the following is the appropriate management of this child? Answer me. If you don't answer me, we're gonna have lunch late. I make you hungry. Try. B, yep, I saw some B. All right, it's the right answer. All right. The reason I bring it up because this is general practice in US that we have to give that antibiotic prophylaxis. But in Thai practice, if you currently in training, you're going to see that nephrologists, pediatric nephrologists don't give the antibiotic. They give their own reasons that they're going to build up resistance. However, if you want to take the USMI exam, you have to answer this. So things that you do every day cannot get you the right answer for USMI exam. That's another notice that I have for you. All right. Okay, next we move on. 8-year-old boy come to see doctor, head 3 weeks, and he's tired, frequently have nose bleeding, and exam, height weight below 5th percentile, blood pressure 152/86 in all extremity, pulse 74, respiratory 16, heart exam normal, pulse strong and symmetrical. UA and electrolyte has been done. Which of the following is the most likely appropriate next step in diagnosis? So this kind of questions that you can do so many things to get the answer or diagnosis of the child, but they want to do that the initial next step. So you have to pick the answer from the list that they have. All right. So the condition show up that this 8 years old boy definitely have the problem with what's the problem? Hypertension. So majority of, I can say like a three quarter of the child with hypertension usually have the cause from the renal cause, right? Or few percent of the heart disease. Very, very small chance you have the essential hypertension. So you have to look for the cause of the hypertension. But initial workup, what you're gonna pick from the choice that they have. Shout out the answer. B. I saw that the sign of B. All right. So this is kind of like an initial thing that you do as a part of screening. So you can do some other thing to get the diagnosis, but deep in detail. But you have to have like the initial labs, and then they let you which direction should you go for further in-depth investigation. You cannot do all at the same time. All right. So this is the basic initial workup for hypertension in the young. That you do CBC, BN creatinine, electrolyte UA, and uric acid, and then see how things change. And if all these things normal, you look for some other thing and you work up more. All right. That's all nephrology that I think that we want to show you. Okay. Next questions. 12-year-old girl has 2-month history of vaginal discharge. She described as clear and stain her underwear, and she says she hates boys, and there's no way she ever have sex and even been kissed by a boy. All right, so this kind of like adolescent medicine that you have to ask them question. So one thing, in the exam, if they say no, that's mean no. But real life practice, if the adolescent tell you no, you just doubt them like a 50%, like, I believe you or not. Okay, next thing. Okay, in this case, if she say no, suppose that she don't have sex. She does never have sex. Okay, she have breast development for 2 years. She thinks that her girl's birth was about a year ago. And genital exam review pubic hair with Turner stage 3. No evidence of irritations or redness, and small amount of odorless clear mucus is seen. Microscopic exam of the mucus review epithelial cell and few bacteria with no white cell. pH is 3.5 and 4. Which of the following is the most appropriate next step in management? Power vote ได้ไหมคะข้อนี้ โอเคค่ะขอ power vote ด้วยค่ะ Get you wake up. So if you have some actions, you can just like be alert. All right, majority of you get it right. So the answer is A. So this is normal, right? The thing about, I think, the Thai student, it's hard for you to get like this is normal and we will not do anything, because majority of the Thai board questions or even the med school questions, you have to do something, get diagnosis. But this is the 10 questions that you're gonna hesitate. Is this normal or is it not abnormal? But in US questions, they want to know, do you really know the normal? Because if you don't know the normal, you cannot diagnose the abnormal or disease thing, all right? So be firm and get the right answer, okay? Leukorrhea can be found in adolescent female, and it can be physiologic, as I mentioned, okay? We screen back, okay? All right, and it's occur the link like for girl, it's occur the link prior to the menarche of the child, and the pH usually lower than 4. But if they have like a alkalotic pH more than 5 suggests infections such as trichomoniasis and some other infections. So the pH tells you too. So in US practice, adolescent medicine, you do all that PV and do all those things as pediatricians. So it's kind of weird compared to the pediatricians over here that we never touch that area much. All right, that's adolescent medicine. And we move on. All right, 11-month-old boy brought to emergency room, fracture of the right femur. The father report that he was sustained as the result of falling off the cliff. The child also known to have bruises on shoulder and back. The rest of his exam is unremarkable. Which of the following is the most appropriate next step in diagnosis? Can we have power vote? You get into action again. Get your box. Punch your answer. All right. 42% answer that the social service consultation, and the answer is D. Okay, you know that this is the suspect case of child abuse, but you know that usually you have to find a clue much more than one. Okay, you find one thing, the fracture of femur, which is kind of like a major injury to the child. To break the bone, it have to be like a high impact. So the story is not fit to the scenario in you file bruise. But you have to look for more clue like a retinal hemorrhage, and to add on to build the case and then consult the social service. Because if you have the weak case and the parents being investigated by the social service, you're gonna get into trouble. So this is kind of fine line that you have to do something. You have to get or correct data more, make it firm case, and then you have to consult. You have to call the social service to evaluate the case. All right. Okay, that's the child abuse. Next questions. 2-year-old girl come to see pediatricians because of lethargy, irritability, and she just start walking, teething, and chews on woodwork around the windows. Exam have tender abdomen. Labs show high iron and ferritin level. The blood smear show basophilic stripping. Which of the following laboratory abnormality should be seen in this patient? So they assume you know the diagnosis. What should you get the labs to confirm? Okay, anyone shout out? We don't have much time to do power vote. So what's the scenario that they give you? Is kind of classic jump out. Okay, let me interpret. Lead poisoning, right? Okay, usually lead is actually in old house. The color painting of the house may contain lead, but nowadays there's a limited amount of lead in the new paint. So usually it's occur in the old house. Usually in the scenario that the child usually kind of like a bite or chewing things and get the crack of the color out in. And how you confirm the lead poisoning? So the answer is this: you have to get to confirm it. Apart from lead level, you have to have increased free electrocyte photopoietin level. Right. Okay, that's the mechanism. And basophilic stripping is the sign of lead poisoning, but the differential diagnosis is the thalassemia, right? But scenario that they give you is kind of lead poisoning. Okay, next question. Okay, 3-year-old boy ingests of 40 tablets of chewable vitamin, and the vitamin contain of other ingredient: vitamin A, C, B6, D, iron, fluoride, and thiamine. All right. The question is, the child is brought to emergency department with no acute distress. That means the child look fine. Which of the following complication may occur if appropriate therapy is not undertaken? Power vote ได้ไหมคะขอ power vote. I'm afraid that you're gonna fall asleep. Get the box. Okay, majority. 1/3 of you answered D. The answer is C. We did get the rest. Okay, it's more important. This is real life practice that if the child just come to you with chewable vitamin, the problem with chewable vitamin is the problem with the iron, and the iron toxic is very harmful and can be fatal because it's occur quite often in daily practice in the US because majority of the house have their own vitamin, even though for mom, grandma, those kind of thing, and sometimes the kids get it and then eat it. So the problem with iron overdose is it can cause acute corrosive necrosis of the stomach. I spell it wrong, sorry. And also the hepatic necrosis. So if it's beyond the time for the lavage thing, you have to admit the child, follow up the liver enzyme, and you have to give that ion chelating agent. So this child cannot be sent home. It's wrong. So you have to keep the child in hospital and investigate. All right. Okay, next question. 3-month-old infant with severe vomiting for the past 6 hours. And she vomited at least 4 times during this period. And the child have difficulty feeding for the past 2 days. Exam, she fussy, swelling over the left side of the head. CT scan showed the skull fracture of the left parietal bone with no evidence of intracranial hemorrhage. The mom explained that she rolled off from the sofa onto the floor yesterday. Which of the following most appropriate next step of management? Okay, so it's pretty much the same, but this is the thing that they want all the doctor to be aware in case of the child abuse, right? In this case, because the explanation is not fit. The skull fracture cannot be explained by just fall off from the sofa less than like a 2 foot. All right. The answer is you have to do looking for more clue. That means maybe you have like the fracture of the femur or humerus, and then add up the case and then bring up the concern to the social service. All right. Okay. Next question. 13 years old girl come for follow-up for the strep throat infection. She been 3 weeks earlier, and the culture. After performing throat culture, the physician asked how school is going, and she did not answer. The mom said that her daughter has missed at least 4 weeks of school. Which of the following is the most appropriate initial step in management? A. Contact with the girl to go back to school as you explore the problem. B. Write a medical excuse for her. C. Tell them you must report her to the school authority for truancy. D. Send the mother for supportive counseling. E. Send the girl to psychotherapy. The answer should be A, right? So for the disease itself, it's not very serious disease. The child should go back to school. But if the teenager, actually this is the problem with teenager, she's not attend school because of the treatment, you have to make sure that there's something like some problem hidden at school or at home. You have to explore. So the thing that you cannot do and not even think about answer is writing a medical excuse. You cannot cover up for the patients. It's gonna haunt you in daily practice. All right. Okay, that's all the school absent and general pediatric. Okay. I think we're doing good on time. Next question. 7-month-old boy brought to see doctor because increased agitation, restlessness. Exam review crackle and decreased breath sound bilaterally. Chest film have bilateral pneumonia, and the blood gastro O2, PO2 45, and CO2 60. Which of the following is most appropriate next step of management? Power vote ได้ไหมคะ ขอ power vote. All right. All right, you get it. Majority of you get it right. So that's the indication of respiratory failure. You have to tilt intubate the child. Okay. Okay, next questions. I helped you out. 12 years old boy with cystic fibrosis come to emergency department. He 3-day history of coughing, productive with yellow and greenish sputum, fever, chill at home, and chest congestion and chest pain that worsening with cough, temperature 39.6, blood pressure 98/68, pulse 102, respiratory 24. He's been lethargic and have rales on the left lower lung field, chest film show infiltration on the left lower lobe. Which of the following is the most appropriate initial antimicrobic treatment for the child? Power board ได้ไหมคะโทษที Okay, majority of you answer A, and followed by C, and the choice is D. Okay, this is the reason I bring this question up, because in US practice, you're going to see a child with cystic fibrosis, but there's very few case diagnosis in Thailand. So I want to bring it up, the cystic fibrosis. The cystic fibrosis is the problem with the iron transport, and it's inheritatory. That means it's transmitted through that autosomal recessive. And as I mentioned, is that ion transport problem. And the test, initial test, you have to do sweat chloride test. That means you gather all the sweat of the patient and then measure the sodium chloride. And the sweat of this child gonna be salty because of the calcium chloride is increased, elevated. Normal people have sodium chloride in the sweat less than 40 millimole per liter. But in cystic fibrosis, they have high, range between 80 to 120, and they usually have the problem with either pulmonary tract infections or the GI. And the pulmonary tract, they have like a severe pneumonia, recurrent pneumonia. In the beginning, they may have infection with Staph aureus and H. influenzae, but after period of time, they turn out to have Pseudomonas aeruginosa, and it's going to be resistant to antibiotic. And the cause of death in this child is the pneumonia. So if you see the child with cystic fibrosis come with fever, with cough, you treat aggressively, and you have to treat with that antibiotic that covers Pseudomonas aeruginosa. So the answer that you have to keep those levofloxacin and combined antibiotic. Okay, A is not enough to cover the child. All right, we move on. Come up with 8-year-old boy come to see doctor because the mom worried that he have daydream, which appear that his school performance has been declined, psychomotor development normal, ECG have bilateral symmetrical 3 Hertz spike and wave discharge. Which of the following is most likely diagnosis? So I go pretty fast, but you can answer immediately. This is recall. Absence, right? Absence seizure. So the only classic EKG for seizure that 3 spike and wave per second is absence. That's the only thing that you remember, because otherwise auto seizure will not have classic EEG as described or can create equation for the exam like this. Okay. Next question. 3-month-old infant come to emergency room because of constipations and behavior change. Examinations reveal ptosis, absence of facial expressions. The child conscious but trouble to follow a toy, and she cry weakly. Saliva is pooling or drooling. Develop generalized hypotonia. Breathing become more shallow. Lumbar puncture perform. Analysis as if within normal limit. Early treatment, which of the following would most likely have prevent morbidity in this infant? So they assume again that you know the answer, and then you have to give treatment. Power board ได้ไหมคะขอ power board. Oh, we have F too, sorry. If you want to answer F, raise your hand up. Anybody raise your hand? No F. All right. And the answer, majority, 32% of you answer D, and the answer is B. And The one who answered B, you know what is the diagnosis? Is that what you have in your mind? All right. Botulism. During my residency, I never seen a case, but they love to ask, even though in pediatric board exam. Okay, it's usually occur in infant, usually with the family who fed the infant with honey, and that's Clostridium spore has been sit in the honey and then cause a problem with constipation, muscle weakness, and even though respiratory failure. So the treatment is antitoxin, right? So you have to remember this. In some questions, they may give you a little clue that the mom gave the honey to the mother. So that's the clue. And this is all the explanation of the muscle weakness, right? So since English is not our first language, you have to skip the questions and see just the crucial words and scan it out. You don't have to read every single word. All right. Okay, next question. Okay, type B infant born blood group A mother, have fetal maternal group incompatibility and mild anemia, weak positive clump test. The child developed jaundice after birth. Bilirubin is 12. Compared to cord blood as 3.5. Physician is concerned that resistance variable level will damage the infant nervous system. Which of the following sites is vulnerable to the injury? This is recall, right? ABO incompatibility can cause hyperbilirubinemia, cause damage on which of the following organ, which of the following neurological pathway? No power word, shout out. Are we running late? What's the answer? A, yes. Right. So you have to know that they want to ask you about the kernicterus, but this actually is rarely being seen right now, but they still want you to know whether, they want to check whether you know. So I just revealed that kernicterus is the problem with the bilirubin that caused the blood-brain barrier and it caused the damage of the child and have all the sign. Be very seen in a daily practice at the moment. Okay, next question. Premature infant have difficult delivery, have episode of arrhythmia and suspected hypoxia ischemic of the brain. After delivery, he's lethargic, apnea, intracranial hemorrhage is suspected, and no obvious trauma. Cranial ultrasound, blood within the ventricle. Which of the following structure is most likely source of the hemorrhage? This is recall questions also, right? That's what is the vulnerable area of the brain of the preemie that's caused bleeding? So what's your answer? What is the fragile area that caused the bleeding into the preemie? You know that the preemie have increased chance of intracranial hemorrhage or intraventricular hemorrhage. And the site should be C, right? This is recall. You have to remember and answer it. Okay, next questions. 6-year-old boy has multiple honey color. This is keyword again, right? So some of you, I guess, that if you see this, you can just go to see the choice and answer it, right? You want to do that? So if you review, use my question quite often. You see 6-year-old boy, multiple honey color. Okay, I pick up the choice already. You don't have to read the rest. You want to answer it? Can we do this way? Okay, answer it. Try it. No, you want to see the rest of the question? You are a serious doctor. All right. So that's that crusted lesion on face, periangular area, forearm, and first lesion appeared 2 weeks ago at his fulcrum. Since the lesion split to hands and arm, it began with small pustule on erythematous base and eventually ruptured to form a clustered lesion. Temperature 38.1, pulse is okay, respiratory rate normal. Remind exam normal. Which of the following is the most appropriate treatment? Right? Because the lesion is impetigo, right? So sometimes just to get the questions answered fast, you just see the keyword and then skip to the choice. It's a little tricky, but it saves time. All right. Next question. Okay, 7-year-old boy come to clinic with abdominal pain for 2 or 3 days, a febrile, no vomiting or diarrhea. Rash on leg, get worse, complaint of knee pain. Exam show keyword, palpable purpura lesions on both legs and buttock. Pain around his ankle, blah, 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 blah. Which of the following? Answer? C, right. You have to do it like this, okay? So the keyword is palpable purpura, and then this is hinoculi pupilla that have the palpable pupilla and also have the involvement with the joint and GI tract, but the child doesn't have a GI tract. All right. Okay, next. 15-month-old boy, come clinic, history of fever, decreased oral intake, running nose, fever 39.5, active, ear clear, multiple small vesicular lesion known on mucosa of the anterior tonsillar pillar and posterior palate. The rest of exam normal. Answer? Herpangina, right? Because hand, foot, mouth, they have to describe the lesion on hand, foot. And abscess also is located in the lips and anterior part of the mouth. Good. Okay, next. 2-year-old boy, fever, irritable, rash for 5 days. Answer? Kawasaki. Okay, good. So you see the age group, and that fever have to be 5 days, and you see Kawasaki, you may just like a circuit pick it up. Oh no, really? Yeah, this is not a good way to do it now because you didn't read the rest. Oh, I trick it myself too. Because if you read the whole question, the child still have fever and rash and without any other sign of Kawasaki. And the keyword is labyrinth of the skin cause separation. So it's the scalp skin syndrome. So sometimes it's tissue, don't go too fast, right? I skip it too. I make a mistakes too, all right. Okay, next one. Oh, this is going to be pediatric cardiology, and I get some review, but we can go fast on this. Okay, the question with a 3-day-old girl have trouble feeding, blah blah blah, and she's busy breathing. I look for the keyword and show bounding peripheral pulse with continuous precordial machinery like murmur. Exam, increased pulmonary vascular marking, and the child gonna go to heart failure. Which of the following would be which of the following is required for this problem? So you know the answer, you know the diagnosis, and you have to get treatment. Power board ได้ไหมคะ อันนี้เตรียมไว้ power board ป่ะคะ ไม่ได้เตรียมเหรอคะ ขอโทษ ขอได้ไหมคะ Just to give you a little. Okay, we have 10 more minutes. Oh, majority of people answer A. Oops, sorry. Okay, the answer is you do closure of the PDA, all right? Because this is the term infant. Indomethacin work effectively in premature baby. So this one, they did not mention premature infant. So for term infant, indomethacin will not work. And if the child develop heart failure, you go for surgery because surgery gonna be ligate or clip the PDA, the patent ductus arteriosus, and all the symptom is gone. You don't waste your time, treat with anti-congestive medications. So the keyword is machinery murmur. But real life, 3 days old, you will not hear the machinery murmur. So this is like creations question. Okay, PDA, I mentioned it. Okay, for older child, asymptomatic, if the child grow up, we can do like a put device, and there's so many devices in the market now that we can do put the device, and this is the diagram of the PDA. This is the descending aorta and pulmonary artery, and this is the PDA. So I just closed by question. Okay, next questions. Healthy 5-month-old boy has been eligible and decreased oral intake for 2 days, temperature 37.4, pulse 220, respiratory rate 50, the radial and posterior tibial pulse are diminished with good brachial and femoral pulse. EKG showed narrow complex tachycardia without preceding P wave. Which of the following is the most appropriate initial step in management? So the question is the most appropriate initial step in management. Power vote ใช่ไหมคะก็ power vote. Majority of you answer A. All right. Okay. And the questions that I got it from the book, the answer is not A. So what do you think what they pick? Actually, they pick C. The tricky is the most appropriate initial step. That's the thing that you can do early on and then just do it. Indomethacin, you have to arrange medication, get the IV and get like double syringe technique. Verapamil, you cannot give to the child less than 2 years of age. Calcium channel blocker never been prescribed to the child less than 2 years of age in the US, but in Thailand, that's different story. All right. And the sign that what they mentions about the pulse is if you still felt the brachial and femoral pulse, that means at least blood pressure should be measurable, right? That's the reasons that why you don't do that that cardioversion immediately. But if you cannot feel the pulse, you have to do cardioversion immediately. All right. So this is the example. So the SVT, supraventricular tachycardia, is the re-entry tachycardia, and when it occurs immediately. When it's paused, it's just stop immediately too. Right, and you have to looking for whether the child have Wolff Parkinson White or not, and the characteristic is the shortened PR and the delta wave of the slow QRS upstroke. And if the child have supraventricular tachycardia and Wolff, the medication that you should not give is digoxin, right? That's the thing that you have to remember. All right, this is gonna be, there's no more power board, don't be worried about that anymore. Okay, this is going to be extensive answer that you have to match. So you have to remember all the items, but I can bring it back when we see the scenario. So that's the lesions, the choice of the heart disease, aortic insufficiency, coarctation of the aorta, just complex congenital heart block, conotruncal abnormality, dextrocardia, endocardial cushion defect, PDA, and supravalvular aortic stenosis. All right. I helped you read out. Don't be straight out. We have 5 more minutes. Okay, 2 days old boy discharged from the hospital with mother, and the nurse noticed he have episode of his eye rolling upward and his body stiffening, and he have generalized tonic-clonic seizure. After stabilization, the temperature 36.5 of febrile. Blood pressure 50/80, pulse 120, respiratory 50. It's kind of okay range for 2 days old boy. Blood gas, pH 7.37, CO2 40, O2 45, bicarb 24, bed deficit 0.2. Chemistry, sodium 145, K5, chloride 111, calcium 6.5, magnesium 2, glucose 90. Exam, have low set ear, cyanosis of the extremity and grade 2 over 6 systolic murmur at the left lower sternal border, loud systolic click. On his chest fin, normal heart size with seal and seal head are noted, but the thymic shoulder is absent. What is the condition of the child? We've been through this. So the child is sick because of hypocalcemia, right? The same scenario that we have early on. But this is an infant, but they want to know the association. So this is the same scenario that the child have that 22q11 microdeletions or that subtype of the George or that family of the George. And what's the heart lesions do they have? Pick one, pick one. All right. It's gonna be, for the George, they usually have the lesions, we group it together, we call conotruncal defect. It can be include that the interrupt aortic arch or truncus arteriosus, and even though tetralogy of Fallot is classified or grouped as conotruncal defect, so you have to answer E. All right, that's 22 microdeletions, the same picture. Okay, next scenario. 5-year-old girl refer for cardiac evaluations because of the newly diagnosis of heart murmur. She's short stature, overweight, pointed ear, and she's being outgoing, friendly personality, and like to talk to everyone she meet. Her mother described her as cocktail party personality. This is a keyword. Okay, and she has renal stone at age of 10 months of age. What is the condition of the child? First, you have to know what her conditions and then know what is the heart lesion associated with the girl. Are you familiar with this at all, that cocktail party personality? No? Really? Okay. Oh, you have to get this first. You know Williams syndrome? Williams syndrome is the syndrome that the child usually have characteristic feature. They call it elfin face. So you guys familiar with elf? Kind of like the thing in the fairy tale. Kind of like a prominent nose, those thing. And this girl, like this patient's friendly, and the heart lesion, they have specific heart lesion is, what is your answer? Okay, I tell you that the girl have Williams syndrome, and you have to get the answer for the heart lesion. What is it? Supravalvular aortic stenosis. This is characteristic that you have to match it. All right, it's kind of like a thing that you have to remember. Williams syndrome is quite being recognized in America, and they have Society of the Child with Williams syndrome too. All right, we move on. Okay, next question. Okay, we have that infant girl have fetal distress and vaginal delivery with vacuum assistation, and the infant climbs spontaneously, but acrocyanotic despite supplying oxygen delivery by mask. The girl is hypotonic and move her extremity only respond to nauseous stimuli. Physical exam, open mouth, protrude tongue, up slant, fissure, low set ear, Simeon class. Diagnosis is Down syndrome. And the heart is endocardial cushion defect. Good. All right. Okay. So we can forget all the option of that heart disease, and this is a standalone question. 19 days old, have serious sore throat. Oh, no, sorry, the patient is 10 years old girl and have history of 19 days of sore throat and arm, leg hurt. extremity pain, rash, irregular bowel lasts about a day, mild fever, erythema around several large joint, elevate ESR, EKG, prolonged PR. Which of the following is the explanation for this finding? Okay. Is that your answer? You know the condition, right? What is this? Rheumatic, right? And rheumatic is caused by toxin. So the answer is what? A, right? Not toxin. Okay. We don't have time to go over this, but I think you know by your heart, you see the case, right? We see it much more often than medical students in the US. Next question. Okay, this is probably what you're looking for. 18-month-old boy, fever 39, 5 days again. And red eye, rash. Answer? Kawasaki. Yeah, this is the real one. Okay, and seem like we're running out of time. You want me to stop? I have a few more questions, but I think that you get overview of all the pediatric questions, and it should be enough. And your brain may be swelling right now. Okay, I think that I should finish now. Thanks.
Thank you for a very engaging and insightful review. Any question? Any question for Dr. Alisa?
You can ask in Thai.
All right, good.
มันเป็น diagnostic มากกว่าแล้วมัน sensitive มากกว่าการทำ X-ray ไอ้ frog leg เนี่ยมันไม่ sensitive กับ specificity มันต่ำกว่าค่ะอันนั้นมันคือมันมี study มาแล้วเซปแทฟคือว่าโดยกลุ่มพวกนี้เขาใช้ไอ้นั่นกันอะอะไรนะไอ้กลุ่มไม่ใช่ต้องใช้ไอ้พวกฟลอกซาซินทั้งหลายเนี่ยซิสติกไฟโบรซิสต้องใช้ไอ้กรุ๊ปเนี้ยเขาเรียกกรุ๊ปอะไรนะลืมไปแล้วเบรนบล็อก
ควินโนโลน
ต้องใช้ควินิโลนเนี่ยแบบว่าต้องคือปกติในอเมริกาเนี่ยควินิโลนเนี่ยไม่ใช้กับเด็กอายุต่ำกว่า14เพราะจะทำให้เกิด bone cartilage ยกเว้น condition เดียวคือ cystic fibrosis เพราะฉะนั้นนี่มันแบบเหมือนกับเป็น choice ที่แบบคุณต้องเลือก quinolone group only คือต้องมี choice ที่ include quinolone มีคำถามอะไรอีกไหมคะดีค่ะมาแชร์เพราะว่าจริงๆแล้วเนี่ยแบบว่าของบางอย่างเขาทำกันรูทีนเนี่ยหรือว่าเราทำรูทีนของเราอีกแบบหนึ่งแล้วเราก็ทำของเราอย่างนี้ทุกวันทำไมเราไปตอบแล้วเราได้คะแนนน้อยเป็นเพราะว่าแบบมัน culture ในการ practice มันต่างกันนะคะมีอะไรไหมคะถ้าไม่มีแสดงว่าทุกคนหิวข้าว
โอเคค่ะพักมีอะไร
หมออลิสาจะไม่อยู่แกออกไปขึ้นเครื่องบินบ่าย3 โมงลองถามคุณหมออลิสาเกี่ยวกับ experience ของแกเทรนนิ่งเมืองนอกเพราะว่าตอนบ่ายจะมีเซสชั่นแต่พวกผมยังอยู่แต่แกจะไปช่วยบอกหน่อยก็ได้ experience อยู่เทรนเมืองนอกเป็นยังไง
ก็ไปเรียน resident เด็กนะคะก็เข้า matching ตามปกติไม่มี connection ไม่มีคนไทยอยู่ด้วยแล้วก็ไปเมืองที่ค่อนข้างเล็กแต่ก็โอเคก็เทรนนิ่งก็อยู่ได้ปรับตัวได้แล้วก็ตอนแรกอยู่ที่มิชิแกนก็จะหนาวหน่อยแล้วก็ค่อนข้างจะแต่ว่าคือเทรนนิ่งมันเทรนหนักด้วยซึ่งช่วงนั้นก็โอเคมันก็ปรับตัวเทรนด้วยแต่พอตอนหลังเนี่ยย้ายมาอยู่ทางแคลิฟอร์เนียซานดิเอโกก็มีไลฟ์สไตล์มากขึ้นแบบมีชีวิตที่ดีขึ้นอะไรอย่างเงี้ยค่ะก็แล้วแต่เลือกเพราะถ้าอยู่พวกมิดเวสเนี่ยมันก็จะ four season คือ culture การเลือกเมืองคิดว่าสำคัญเหมือนกันนะว่าชอบยังไงแต่ตอนแรกนี่ก็คือแบบผ่าน match ไม่มี option ใช่ไหมคะก็ได้ Midwest แต่ก็ได้ไปปรับตัวพอสมควรการทำงาน Midwest เนี่ยคนเนี่ยทำงานหนักกว่าเหมือนกับเครียดกว่าแล้วก็โดยเฉพาะหน้าหนาวเนี่ยค่อนข้าง stressful มากเลยเพราะว่าอย่างถ้าเป็นหมอเด็กเนี่ยก็หน้าหนาวนี่แบบ คือบ่าย3พระอาทิตย์ตกดินแล้วก็ตอนเช้านี่แบบพระอาทิตย์ขึ้นประมาณ9 โมงเช้าวันหนึ่งมันแค่6 ชั่วโมงแบบในชีวิตไม่เคย appreciate กับแสงแดดเท่าตอนอยู่มิชิแกนอีกแล้วพอกลับมาเมืองไทยก็ทำไมเยอะจังเลยอะไรเงี้ยแต่ตอนนั้นมันจะ depress มากหน้าหนาวแบบว่าเมื่อก่อนตอนเรียนหนังสือว่าโอ๊ยแบบเคยมีคนเมนชั่นwinter blue นี่ไม่เคยรู้จักเลยใช่ไหมพอไปอยู่ทาง Midwest เนี่ยก็จะรู้จักว่าเราบางทีเราทำงานเราต้องไปราวอร์ดตั้งแต่6 โมงเงี้ยก็จะไม่เห็นพระอาทิตย์กลับบ้านก็ประมาณ2 ทุ่มแล้วถ้าเกิดอยู่เวรเนี่ยพอดีโรงพยาบาลที่อยู่เนี่ยเป็นแบบ regional hospital ที่รับ refer คนไข้เด็กทั้งหมดแล้วก็มี pediatric ICU ไม่ลิมิตคนไข้เพราะฉะนั้นเนี่ยก็รับบางทีนี่แบบถ้าหน้าหนาวนี่แบบว่าเป็นพวกเป็นเด็กมี bronchiolitis อะไรเนี่ยมาบางทีคืนละ16-17เคสไม่ลิมิตแล้วเราก็ต้องรับหมดแต่ว่ามันก็ผ่านไปคือถ้าทำมันก็ผ่านไปได้ทุกคนคิดว่าแบบถ้าใจเราสู้มันก็ผ่านไปได้แต่ว่าโอเคพอผ่านแล้วก็ทำให้แบบว่าเราปรับตัวได้ดีขึ้นอะไรอย่างเงี้ยค่ะแต่ว่าเนี่ยตอนนี้ตัวเองอยู่รามานะคะเตียงเนี่ยลิมิตนะคะแล้วก็บางทีเนี่ยเตียงมันก็ไม่ค่อยว่างนะเรสซิเดนต์ก็บ่นแล้วบ่นอีกงานหนักนี่แบบว่าคือฟังไม่เข้าหูเลยค่ะเรสซิเดนต์คนไหนบ่นงานหนักนี่อย่ามาพูดกับดิฉันนะคะ ประมาณว่า
How's the life as single women
ค่ะ women ก็ไม่แตกต่างคือชีวิตตัวเองไม่รู้เป็นไงนะคะตอนเข้าไปเนี่ย MASH ใน Pediatric Program ที่เล็กนะคะรับ6 คนผู้ชาย5ผู้หญิง1เข้าไปเป็น Fellow ของที่ซานดิเอโกเนี่ย Fellow ก่อนหน้านี้มีผู้ชายหมดเลย Attending ก็ผู้ชายหมดเลยเข้าไปเป็น Pediatric Cardiology Fellow ผู้หญิงคนเดียวคือชอบไปอยู่ในที่เป็นดงผู้ชายอ่ะไม่รู้ว่าไงแต่ก็โอเคเขาก็ยอมรับได้หรือไม่รู้เขาขยาดไว้ก่อนแต่ช่วงหลังๆเขาก็รับผู้หญิงอีกนะคะคงไม่ทำให้เขาขยาดไปกลับมาทำงานรามาก็ที่หน่วยถ้าที่รามานี่ใครผ่านรามาก็จะรู้เคยมีตำนานว่ารามาใน Pediatric Cardiology เนี่ยจะไม่รับผู้หญิงก็กลับมาเป็นผู้หญิงคนแรกใน Pediatric Cardiology รามามันไม่รู้ว่าจะว่าไงว่าอาจจะเป็นเพราะตัวเองหรือว่ายังไงแต่ว่าตัวเองก็อยู่ได้ในที่ไม่ต้องมีผู้หญิงแบบไม่ใช่บอกหมายความว่าไม่ต้องมีผู้หญิงมากก็ได้แบบว่าอย่างตัวเองตอนนี้เป็น attending อยู่รามาโอ้โห resident ผู้หญิงนี่ต้องเกาะไปกินข้าวเป็นกลุ่มเนี้ยตัวเองไม่จำเป็นอ่ะแต่โอเคก็มีเพื่อนอ่ะ nurse ก็เป็นเพื่อนกับเราได้อะไรอย่างเงี้ยค่ะแต่ก็คือ purely ไม่ได้ผู้หญิงอย่างเดียวนะเพราะว่าอย่างตอน 10 resident ก็จะมี med peace resident ที่เป็นผู้หญิงแล้วก็มีพวก internal medicine ที่มา rotate แล้วก็มีเพื่อนได้ก็ไม่ยากรอดตายมาได้
Okay, as a token of appreciation for her lecture, we'd like to present her with a little small gift. So may I have the pleasure of having Professor Somkit Sidaronon to present the gift to our speaker, Professor Alisa Limsuwan. Thank you. I'm sure that you all very hungry right now, but I have a few of important announcements to make, so please bear with me. The first one is that for those who register and has already made your payment, and if you want to have a certificate of attendance, please sign your name. Please sign your name at the registration table. Okay. And the second announcement is that this is good news, I think, is that for the same thing, for those who register and made payments, you will also receive CD, all right, video CDs, which contains all the PowerPoint materials. This is from yesterday. You will get it today. So please make sure to pick that up after lunch at the registration table. Also, you will have a DVD recording of the entire workshop. This is for yesterday, just for yesterday, okay? But actually, you will get this every day. But we already have that ready for yesterday's session. So, and the last one is that Well, if you have registered but did not make any payments or anything, and if you're interested, you can still purchase the DVD and CD of the same materials that the one that I mentioned previously get. So you can do that also, and it is available right now at the registration tables, or at the at the secretariat table. So you can do that and purchase if you like. The price of the DVD is 100 baht, and for the CD presentation is 50 baht. So if you're interested, it's available. Okay. เข้าใจไหมครับเข้าใจมีเวอร์ชันภาษาไทย Okay. All right, thank you. And oh, I almost forgot. So those who register and made payments, lunch are available in the luncheon room. So please proceed to the room. But for the others participants, especially with the blue name tag, lunch boxes are available for you outside. Thank you. And be back by 1. Okay? Thank you.